Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of Health Quest, St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I'm the executive producer and host of the show. We're celebrating our 12th year and we're very excited to be back on the air with a whole new group of physicians that want to educate you about how to take better care of yourself and how to know when you should be seeing your physician. I'd like to welcome back today Dr. Janine Parker. Dr. Janine Parker is a board-certified physician in 4 different areas of medicine, very unique, very educated, special lady, and a fantastic physician, a leader in the medical community. Dr. Parker, welcome back.
Thank you.
We're going to continue our discussion now on COPD, or chronic obstructive pulmonary disease. And what we want to talk about, Dr. Parker, is some of the early work, which I want to thank our Xavier students, Xavier University School of Pharmacy, who's done research for us, and for the Slidell Memorial Hospital Pharmacy Residency Program led by Dr. Keisha Gant, and her administrative or her residents, pharmacy residents in the program, who assist us in doing our research for the show. So thank you for that. And Dr. Parker, thank you again. So going back to over 200 years, we see that scientists, physicians, researchers were trying to understand what COPD was, and they had different definitions of it. So Bonnet back in 1679 said it's a voluminous lung. And we talked about that because the alveoli sort of they're not grapes anymore, they just become sacs.
Correct. And so the lung volume increases. And so what Bonnet recognized was by percussing the thorax, you could hear that the lungs were larger than they should be. And so it was a voluminous lung disease. And
so he would do that, is that a differential diagnosis, like different patients, they would know the sounds, or maybe one, would it be in both lungs at the same time? Or
correct.
It would be in both lungs?
Right, so both lungs get too large, and when you're percussing the body, you hear this resonant noise when you tap on the chest wall that goes down longer than it should. I mean, you should get to abdominal contents about here.
Yeah.
But in patients who have COPD, it can all go down to their belly buttons.
And you know, from a layperson perspective, you would think, oh, well, gee, one of the things I'm trying to do is I'm trying to increase my airflow and trying to get more volume in and out. And you would think that that's a good thing, but it's not good because it's like the lungs are stretching out.
When the lungs are too big, they flatten the diaphragm. The diaphragm is the main muscle of breathing. And the diaphragm works best when it's a curved muscle. When it's flattened, it is not at a mechanical advantage, so it cannot work as effectively, and so you cannot breathe as well.
All right. Then we get up to 1769 with Morgagni, and he had turgid lung.
Yeah.
Okay, yeah.
It meant it had a lot of air in it, just a different word for saying the same thing.
Okay. And now in 1814, Banham said Cara.
Cara is mucus, so chronic bronchitis.
So
recognized
identifying different components of COPD.
Correct.
1821, hyperinflated lungs. And this particular person, Laennec, developed the stethoscope.
He did.
Which is one of the primary tools that you must have to use in your diagnosis.
Absolutely. And the stethoscope was a great advance, especially back in the day when bathing wasn't quite so frequent. So now you did not have to put your ear to the patient's chest. You could actually use the stethoscope to hear the lung sounds.
Fascinating. Now, we were speaking earlier about a spirometer, and that's there's a spirometer, and then there's something else that does measurement of air volume, or?
A spirometer measures the inspiratory and expiratory volumes and the rate at which you inspire and expire air. And that is our primary tool for diagnosing COPD. That is the gold standard for diagnosing COPD. There are peak flow meters, which we use in asthma. There are incentive spirometers, which everyone leaves the hospital, where you pull up the big ball to expand your lungs and decrease atelectasis. But a spirometer is a tool for measuring lung function and diagnosing COPD.
Right, so 1846, Hutchinson invented that.
Right.
Now we're getting into 1916, Osler, excessive pressure.
Again, the hyperexpanded lung fields creating pressure on the other organs. If you look at a chest x-ray on someone who is severely emphysematous, you notice that the heart is squeezed into this little center space instead of sitting in the lower part of the left chest. But the lungs become so hyperexpanded that the heart becomes vertical.
Wow. Now we're all the way up to 1944, dyspnea.
Shortness of breath.
Shortness of breath on exertion.
Correct.
And one of the very prominent symptoms of COPD is when you have this on exertion, when you have dyspnea on exertion. I'm having difficulty because I walked a mile, a half a mile, or to the mailbox, right?
Correct.
Or to the kitchen.
Correct. This is the most common symptom that brings patients in.
Now, in 1956, we're becoming more elegant in our discussion and in our research, and we have one of the gold standard, perhaps, textbooks, or one of the early textbooks.
One of the early textbooks that actually gave it a name: chronic obstructive pulmonary disease.
Okay, and then in 1962, the Thoracic Society, ATS, developed the standards, and these are
Correct.
the guidelines you use?
Not quite those.
Okay.
We now use the gold standards, which is the global standard of what constitutes COPD. But ATS did codify the standards of COPD in 1962. Before then, it was kind of an amorphous, well, shortness of breath, and they had other diseases kind of lumped in there. Once upon a time, asthma was lumped in under COPD, but that's since been removed. Now, there's an asthmatic COPD that still falls under COPD, but truly asthma is not COPD.
So what's fascinating here is that you see over 200 years of research and trying to define and trying to identify, and what the physicians and the scientists were working through, it appears, is that this has several different faces to it and several different facets to it. And so I imagine that was some challenging work for those early scientists.
Yes.
Now, we talk about the treatment history. Can you take us through some of these early medications and approaches?
Once upon a time, we used potassium iodide to treat obstruction. Thankfully, that has gone away. Ephedrine was a sympathomimetic, which sped up the heart, did give some bronchodilation, but made you so jittery you were utterly miserable. It was always prescribed with a sedative because the effects of the ephedrine were so bad. Theophylline is a much older drug that we don't use anymore, except in very rare instances, because it has a very narrow safety spectrum.
Right.
If you give too little, it does nothing. If you give too much, the patient is adversely affected.
Right.
So we have safer drugs now, and so we don't use that anymore. Isoproterenol is the first inhaler that we had. Again, a lot of other side effects with it, and we've moved away from that. Initially, we did not use steroids or oxygen, and we thought you should be at bed rest, kind of like treating tuberculosis. You know, we don't want to stress those lungs. But we still use steroids, but in a limited fashion, mostly as an inhaled drug. Only when you're having an exacerbation should you be on oral or IV steroids. Oxygen, we now know, is a very important treatment for patients who are hypoxemic, meaning their oxygen levels in their bloodstream are low. The reason this is so important is because your head, your brain, and your heart don't work when there's no oxygen. You know when you exercise hard and your muscles burn?
Yes.
That's anaerobic metabolism. So those muscles can function if there's not enough oxygen. Your heart and your brain don't work so well. So you lose heart muscle, you lose brain cells if you don't have enough oxygen. So if your doctor tells you you need to be on oxygen, you need to wear your oxygen. It's not that you're going to become dependent on it. If you need oxygen, you need oxygen. People sometimes become acutely ill and they have to go home from the hospital on oxygen and then are able to come off of it in time. And we will measure that and we'll get you off as soon as we can, if we can. But if you need to be on oxygen, please wear your oxygen.
And don't take it off when you get in the shower because you're not going to hurt it.
Correct. It's plastic tubing. Dry it off.
Yeah, it's probably good to wash it.
Yes.
Let me ask you this, and this predates you, but perhaps not me. There were some over-the-counter medications. Ephedrine, is that one of the early ones?
Yes.
I seem to remember back when I practiced pharmacy in the late 70s
Yes.
that you could still get some of the early medicines.
I can't think of the name of it, but it was over the counter, and it was in a inhaler device as well, and it was just dangerous because it would lead to profound tachycardia.
Right.
And these people were taking it without a physician's advice and frequently cause cardiac symptomatology.
Absolutely. And then Isoprel became, in that era, became the gold standard.
It was what we had.
It's what we had, and it did work.
Terbutaline.
Terbutaline, it worked. It worked. Mechanical ventilators, that's the very acute situations, right? I mean,
Right, that's when you are very, very sick. We now have non-invasive mechanical ventilators, and our patients with severe COPD will wear those at night to rest themselves.
What is that, Dr. Parker? Is that it's a ventilator?
It is a ventilator.
It's
gives you
not a CPAP, right?
Correct. Now, looking at it, you might mistake it for a CPAP machine. It's larger than a CPAP machine, but it's that same mask.
Okay.
But we set those with how much volume, how frequently, how much oxygen. So it truly is a ventilator.
Does it have an oxygen tank or a concentrator?
A concentrator.
Concentrator.
So that we can rest you at night and get rid of that waste gas that you may not be able to do so on your own anymore.
Yeah. For a patient who would be using that, would they also have a pulse oximeter at home?
You would hope.
Right. Standard, pretty standard. You would hope that they...
Yes.
Yeah. And do folks with COPD, is it common for you to recommend, and is a pulse oximeter something that they would use as maybe a baseline indicator of how their saturations are? Is that useful?
It is very useful for people who have marginal oxygenation.
Marginal.
So I'm short of breath walking. Well, what's your pulse ox say? Well, it says I'm 94%. Well, then keep walking. Okay, you're fine. If you're 88%, I need you to stop and catch your breath and let your saturation improve.
Okay.
And you can now buy them at drugstores, at Walmart, any place like that, for about $40, and they're very helpful.
Right.
People who are on oxygen need to have one, obviously, to make sure their saturations are staying up.
And I'm not that familiar with the concentrators. Adjustable to different levels,
They
right?
are, but you need to talk to your doctor before you go adjusting your rate, because some patients, not all like we used to think, but some patients are very sensitive to their carbon dioxide levels. And if you increase the oxygen too much, you just don't breathe very much. It's not nearly as common as we used to think it was, but there are some patients who depend on their breathing from their oxygen level. The rest of us breathe because of our carbon dioxide level.
The carbon dioxide is triggering us to
Take a breath.
Inspire, right?
Correct.
Yeah. And so, being a childhood asthmatic and occasionally an adult asthmatic, not praise God, not COPD, I don't think, I hope not. Corticosteroids, very, of course, when you have an acute flare-up, it's been my experience, both, as an allied health professional and as a patient, that this pretty much is the gold standard. If you're in some type of acute situation, you're going to get these things.
You are.
Injection or otherwise.
Correct.
And they work quickly.
Mm-hmm.
And they do have side effects.
They do.
And my wife does not like when my physician puts me on those because I'm up at midnight cleaning the house and painting and doing everything. Yes.
Yes.
All right. So antibiotics are in the armamentarium of what you have to treat COPD. Mm-hmm. But antibiotics, lifesavers, we know, mm-hmm. and also, they've gotten some bad press because it may be
overprescribed.
Overprescribed for non-bacterial or you know, outside of what really they should be used for. So how does this play into COPD?
Okay. If you have an obvious bacterial infection, it will lead to a COPD exacerbation. And so at that point, we will treat you, and these are oral antibiotics that are listed here. We will treat you with an antibiotic. The ones that we tend to use most are doxycycline and azithromycin, because these antibiotics also have anti-inflammatory processes. So not only do they treat the bacterial infection, but they decrease some of the inflammation. There are studies out now that show that patients with significant COPD, the Class D, the severe COPDers, will have fewer exacerbations if maintained on azithromycin 3 times a week. The argument that you'll get from other pulmonologists and researchers is then you're adding to resistance, you know, so that you become resistant to the whole macrolide class.
That particular individual or
That
the
particular
general
individual.
population?
Well, if enough people are exposed to it, then it becomes a process for the whole population. Usually it's for this individual that we're talking about.
It's a very limited class of people, right? I mean, this sounds like a severe approach.
Correct. So we don't normally use antibiotics unless there's an indication. We tend to pick the azithromycin and the doxycycline first line, but any of these are useful. We try not to use too much of the fluoroquinolones, which is the levofloxacin, because we're seeing a great deal of resistance in the entire country and the world to the fluoroquinolones because they're so severely overprescribed.
Right. But it is important, I think, that our community realizes that physicians working in concert with pharmacists and researchers are doing a lot of work on appropriate utilization. And there's now a standard from the Joint Commission, the Joint Commission, which is an accrediting body, that has a program called antibiotic stewardship. And Dr. Parker and Dr. Faith Joubert were pioneers in actually working and developing an antibiotic stewardship program at Slidell Memorial Hospital.
That's Dr. Joubert and Dr. Gretchen Blondeau.
And Dr. Gretchen Blondeau. And dare I forget to say Dr. Blondeau, because she is an amazing, talented doctor of pharmacy. And what we saw by the appropriate, now antibiotics of course can be overused, but through antibiotic stewardship and working in harmony with other healthcare professionals, we've seen demonstrated at Slidell Memorial that we've been able to reduce both the dose and the class so that we can use a lower, quote-unquote, lower level, which is much better for the patient and helps to reduce the resistance in those severe infections. So great progress is being made through a lot of hard work of our medical staff and our doctors of pharmacy, Dr. Blondeau. So, you know, I look at doxycycline and I think, wow, that has been around for a long time. Still a valuable drug in the treatment.
It is. It's one of our first line in our armamentarium for antibiotics for lower respiratory tract infections.
And I go back to, and I look at the amoxicillin, been around a long time.
But not plain amoxicillin.
It's the
okay. It's the amoxicillin with the clavulanate acid in it. Amoxicillin's great for your mouth.
Yeah.
You need the clavulanate to work in your lungs.
Got to hang another molecule along there to make sure that they're not resistant to it and that you get to where it needs to get.
Correct.
So antibiotics play a significant role because there can be infections, not unusual, not uncommon, in COPD for the treatment of COPD.
Correct.
All right, corticosteroids. Well, it seems like these, there's a list of them here.
Yes.
And I would have to say that looking at Big Pharma, and we don't want to attack Big Pharma too much today, but Big Pharma has been very successful in developing several different molecules, each with its pluses and minuses, mostly good, and very helpful. And what, in your opinion, the inhaled corticosteroids, where do they fit in?
The corticosteroids are used for patients with COPD who have more moderate to severe symptomatology. The problem with an inhaled steroid is there is a tendency, it's not a big tendency, but a tendency to have more bacterial infections. Obviously, a steroid works by decreasing inflammation, by telling the white blood cells, no, 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 we don't need you here, we don't need you fighting off anything, relax, because when the white cells are activated, they release molecules into the body that say, attack, attack, and so you get inflammation, you get fluid in the lung, you get more white cells, and that clogs up the lungs. So by giving people steroids, it's fine, it's calm, be quiet, and the airways are more open. So we use them when we need to. If we don't need to, if you have mild COPD, you should not be on an inhaled corticosteroid. We use them acutely in an exacerbation, and if you do exacerbate, the studies show that you should then be on an inhaled steroid. Some patients with COPD don't have exacerbations for years, and so those patients shouldn't be on it.
And so the actual dose, like if we look at an injectable steroid or an oral steroid versus the dose on these, safe to say that the inhaled dose is much lower?
Right, and it tends to stay in your lungs.
Yes.
Okay, so that you don't get the systemic bad effects that you get from steroids that you either take orally or IV. So you don't get the diabetes, you don't get the bone wasting, the thin skin, the buffalo hump, the round face, all those things that people who have seen people on chronic steroids are very well familiar with. So this steroid tends to stay in the lungs. There's a little bleed through, but it's minor. And so you put the drug where you need the drug.
And that's, one of my concerns, having used this, and I'm sure a lot of folks out there, like, steroids just have this kind of a negative connotation. People are like, oh my God, I don't want to use that because, I don't want to, if I really need a steroid, I don't want to be on a routine steroid.
Correct.
So, but
you don't want to be on a routine oral steroid.
And that's the big difference here, that this one primarily stays in the airway system.
Right. Now recognize that your mouth is the portal of entry, and if you leave steroids in your mouth, you will get thrush, which is a yeast infection, which makes your tongue hurt and your throat hurt, and it's a very miserable thing. So if you're on an inhaled steroid, you must rinse your mouth every time you use it so that you don't leave the residual of medicine in your mouth.
Excellent point, thank you. The oral corticosteroids, we talked about them. There are 2 or 3 different ones here. Any one more prominent in your treatments?
No, methylprednisolone we tend to use in the hospital as an IV. The prednisone we tend to use most. Prednisolone we don't use as much. It works just fine, but prednisone is the go-to oral steroid that everyone's familiar with.
Right. For more, and not for like a chronic treatment, more for those exacerbations,
Right.
those flares.
You will see the occasional chronic patient on a very low dose of prednisone because of financial constraints. Prednisone is very, very cheap. Our lovely new drugs are not.
No, you're right. So bronchodilators, now moving into a different class of drugs, what do these drugs do?
They open up your airway. They literally increase the diameter of the airway, so it is easier to get air in and out.
Is this what you would call, are these rescue inhalers? Is that what that is?
There are short-acting bronchodilators, which are rescue inhalers, and long-acting bronchodilators, which are maintenance.
Okay. Let's talk about the LAMAs, and what is a LAMA?
A long-acting antimuscarinic agonist.
Okay. All right.
All right.
And so this category here, we've had we've had significant development by Big Pharma, and each one probably has a little different niche in different patients. Which one do you see that is sort of your go-to here as a starting point?
Well, Spiriva is the old standby that we've had, and probably the longest one out. I hope I'm not offending any pharmaceutical company, but it was the first one that we had for a very long time. It's now available in 2 different formulations, and all of the LAMAs work by increasing the airway diameter, but not making your heart go fast. And so that's one of the really nice things about the LAMAs, is you don't see the tachycardia associated with them that you do with the beta agonist in bronchodilators. There's a little concern with people who have difficulty urinating because it can make it more difficult, and people who have one form of glaucoma need to check with their doctor.
Right.
It can also cause dry mouth.
All right, let's talk about the LABAs. What's a LABA?
A long-acting beta agonist. Okay, so another category used all the time. The Bravana and Performist you see here, that arformoterol and the formoterol are available as an inhaler. The others are in metered-dose inhalers or other devices.
And that is a SABA?
A short-acting bronchodilator,
And
yes.
that one, there is no commercial bias here. These are just things I found in the medicine cabinet and brought for our doctor today. And let's talk about rescue. Did we talk about rescue?
We did not. So you handled your rescue inhaler. So that is albuterol, and it is used every 4 to 6 hours, 2 puffs, not 1 puff, 2 puffs, not more than every 4 hours. If you're having to use it more often than that, you need to be talking to your doctor that day or moving into an urgent care and emergency room. There's another formulation called levalbuterol, which is just the isomer. You know, most molecules have a right hand and a left hand. Mm-hmm. So what they've done with levalbuterol is split it in 2 and taken the tachycardia part out of it, which decreases kind of the jitteriness and the tachycardia. But of course, you pay for that benefit.
Absolutely. So our last slide that we're going to talk about today is maintenance therapy. And Dr. Parker, I'm not going to punish you by asking you to go through this litany of medications, but if you could briefly describe what is the goal here of this type of treatment?
The goal is to give you a medicine that you need to use once or at most twice a day, because compliance increases with the decreasing frequency that you have to take a medicine. So the medicines that you only have to take once a day are more likely to be taken, or medicines that you take twice a day and it sits next to your toothbrush, you're more likely to take, you're more likely to do better.
And there's a lot of study out there that talks about compliance in different times of the day. So we're going to end our discussion here, and we are so appreciative and thankful for your generous offer of time today, Dr. Parker, and for your education. COPD is a serious disease. It's complex. It presents in many different ways, as Dr. Parker has illuminated today. For more information, or if you have questions about it, or if you think you have COPD, talk to your physician. And if you'd like to speak to Dr. Parker, she can be reached at 985-641-5523. Dr. Parker, thank you again. From all of us at HealthQuest, we thank you for joining us today. Have a healthy day.